thank you all very much. A big welcome to our board meeting. Just a reminder, this is a meeting in public. It's not a public meeting, and therefore we won't take any questions or comments from members of the public until the end of the meeting, and time permitting we'll take questions from members of the public at that point. Just a reminder that the meeting is being broadcast online and it's also being recorded. The recording will be uploaded onto the ICB website after the meeting, and a version with British Sign Language will also be produced and uploaded. Can members remember to do what I'd forgotten to do, which is turn on your microphone when speaking? That's helpful for people if they need an induction loop, but it's also important for recording of the meeting. Just to let you know, there will be a fire alarm test at 2:30 today, and it will last for 20 seconds. If it lasts longer, then follow the fire exit signs. But it should be a 20-second alarm. We've received apologies from Matthew Kershaw, the place member for Croydon, Joe Farrer, our partner member from Community Services, Shannon Kataya, our place member from Wandsworth, and Mike Jackson, our local authority executive lead. I can confirm that the meeting is quorate, and therefore we can start our meeting. Could I ask if there are any declarations of interest that people haven't registered on the public register of interest which are relevant for today's meeting? I'm assuming no. Thank you all very much for that. And we note the register of interests. If we can go to the minutes of the last meeting held on the 15th of May. Hopefully you've all had a chance to look through these. Many of you will have had a chance to comment on draft minutes prior to this meeting. Are people content to agree those minutes? I will take silence as assent. So we approve the minutes. Can I ask us to consider decisions made in other meetings? Sarah.
Thank you. So we've had two meetings where we made decisions since the last board. One, we approved the new leases for 120 the Broadway, and we're currently now on one floor here for the offices. There are and some other space, which is a reduction on where we were before. We've also approved the financial plan and the operating plan, which is in the papers later on. On the second meeting, we also approved the annual report and accounts for this year, and an award of contract for Greenmead and Persade Special School. We will actually be putting those papers for the annual report and accounts in public prior to the AGM at the end of September.
People content to note the decisions made in other meetings. Thank you very much. Moving on to the Chair's report. First of all, I would like to note that Dick Sarabji stood down as our non-executive member in June. That was to take up an appointment of Vice Chair of Central London Community Healthcare, one of our providers in South West London. So congratulations to Dick on being appointed as the Vice Chair, and thank you from all of us for his contributions. We also will be wishing Ruth Bailey a farewell at the end of August, when she stands down as her role as a non-executive member of the Integrated Care Board. And again, thank you, Ruth, both for chairing the last Part 2 meeting, but for all of your effort. And I know prior to my appointment, you chaired meetings for quite a considerable number of months. So thank you for that. Other things I just wanted to highlight since my last report. Really pleased that I was able to lead part of the NHS delegation at London Pride this summer. It was one of the few nice days of the summer, a bit like today in terms of weather, and we were celebrating the Fast Track Cities initiative and the likely eradication of the transmission of HIV by 2030. Fabulous event, really well attended. I'd also like to thank colleagues who participated in the South London Digital Conference, which happened around 6 weeks ago. It was a huge amount of effort from both South West London, South East London, ICB, and from our colleagues at the South London Health Innovation Network. Truly successful day, around 250 people attended, and a whole range of innovative solutions for healthcare were discussed at that meeting with providers of the technology, with trusts, with general practice. It was a very, very vibrant meeting, and I think bodes well for the future and our embrace of technology. We can be proud in South West London that we've gone a long way in terms of adopting new technology to improve the quality of care for our patients. But the South London event indicated that there is so much more we could be doing in that space. One final comment is that some of you may have noticed that since our last meeting, there has been a general election. We have a new government, and the board would like to congratulate those members of the health team who we'll be working with at the Department of Health and Social Care. And we look forward to a focus upon longer-term strategic issues moving forward. We will need to potentially refresh a number of our strategic priorities in the light of that new government as the emerging priorities of that government become clear. But we'll bring that back to future board meetings. And that was all I was going to say. So any questions on the Chair's report? If not, I'd like us to move on to our substantial item on engaging with our communities who face health inequalities in partnership with our voluntary community social enterprise colleagues. So I'm going to hand across to you, Charlotte, if I may.
Thank you, Chair.
Actually, I think I'm doing the introduction on time.
I was going to introduce you, Mercy.
Oh,
I was going to say lovely things about you. Yes, so I was going to say Mercy's going to do a brief introduction in her role as chair of the Engagement Assurance Group. And this piece is really about how we engage with communities who experience health inequalities, but in partnership with our voluntary community and social enterprise sector, which we will refer to in this session as the VCSE sector, as it's quicker and easier. But Mercy, over to you.
Thanks, Charlotte. Yes, I'm just going to be brief. As Charlotte said, I chair our People and Community Engagement Group, which meets quarterly, and it's a really important group because we get a real feel about what's happening across the system in how we engage with our communities, and the vital role that the voluntary and community and social enterprise sector kind of plays in this. I've obviously got a background in the voluntary sector, so I particularly understand how important it is when we're addressing health inequalities, but also the general health and public health of our communities, and the vital role that often very small organisations, as well as the larger ones, can really play in making a difference in this way. So just wanted to kind of point out that really this is a journey we go on together for, because it's a complex sector, and just as we as the statutory sector and health services feel complex to the people out there and our patients, it sometimes might feel that it's complex as well for us to understand the intricacies and the diversity of the voluntary community and social enterprise sector. So it's really about building relationships, I think, and we try quite hard to do that. We actually are dealing with a great many different types of organisations working in very many different ways, and I think we're going to get a hint of how we can do that when Sarah talks about the Alliance. But I really wanted to just say those things about this being a journey, and that there are many challenges really for both sides to come together and really make a difference for the communities we both serve.
Thank you, Mercy. So I'm going to assume that you're going to follow on your laptops the slides. So if you just go to slide 26, I promise we're not going to talk to all of them, are we? So if you just go to slide 26, which is an outline of what we've got in the pack. But I suppose in brief, I think our summary would be, so, you know, when we were established as an ICB by NHS England, all the national guidance said, yes, you need to work closely with the VCSE sector as a strategic partner, and all those guidance documents are in the pack. But I think this session is more about showing why that partnership with the VCSE sector is absolutely fundamental to delivering our 4 core purposes of this board, really, which is tackling health inequalities, improving outcomes in population health, making sure we spend our NHS pounds wisely, and then supporting communities more broadly with their social and economic development. So if you just skip to slide 29, there's a nice infographic for you. So we know that the voluntary sector delivers services. We also know that they amplify the voice of different and diverse communities and help us address health inequality, particularly for those most marginalised groups. And those are often the groups who experience the poorest health. So if you skip to slide 30 and 31, so this sort of talks to you more about the skills and knowledge of expertise in that sector. And it isn't a homogenous group. As Mercy said, you know, it can range from national experts to medium-sized charities to small community organisations. So, you know, in essence, if you go to slide 32, you know, if we have this close partnership with the sector, it helps us make better decisions about service change and how we spend our money. It helps us tackle health inequalities by understanding our community's needs and then developing solutions together. And often these VCSE organisations can act as glue for our communities, so cutting across all the artificial boundaries, if you like, that our organisations have, you know, even in the NHS or with social care or with housing, the VCSE can kind of connect all that together. And that is possible due to one thing. And that one thing is trust. So if you go to slide 33, it's such an important point, it's got a slide all of its own. And that is because through decades of hard work, so many of our VCSE organisations have earned a really deep-rooted trust with our communities. And that is something that our statutory services simply do not have. So if you go on to slide 35 and 36, that's just a little outline talking about what we have tried to do in South West London to really capitalise on all that skill and expertise. So we've established our VCSE Alliance, so all of the 6 places VCSE organisations coming together to have a stronger voice and share best practice. We've funded a dedicated post with my colleague Sarah. We've strengthened the VCSE voice in decision making. So on 36, slide 36, you can see the little orange tutti frutti, which show where we have VCSE representatives in our decision making groups. And I suppose it's important to say, just because we've got reps on the groups, it doesn't mean we've fixed it. So it doesn't mean that we are working as equal partners everywhere, but I think it's a good start. We've strengthened our kind of strategic partnership work. So many of you will have been at the AFC Wimbledon event, the conference, where we brought together 300 people to talk about our strategic priorities for the partnership. And a third of those 300 people who attended the conference, so over 100, were from VCSE voluntary and community sector organisations. So really important. And as we've talked about at this group before, you know, we have invested in the VCSE sector. We've had the Health Inequalities Fund, our ICP Priorities Fund, and now our new kind of grants-funded insight work. So that's kind of the progress we've made, but I think there is still an awful lot for us to do. So if you just go to slide 37, so this is a really important slide because this is about the challenges that the VCSE sector face. And when Sarah and I talk to the sector, I'm just going to talk about 3 important ones that the sector wanted us to talk about. So the first one is our willingness to see the VCSE as an equal partner. The second one is basically our lack of understanding about the sector. And the third one is our inconsistency. So our inconsistency in investment and our inconsistency in engagement. So on the equal partner point, we have made some good progress getting VCSE round the table in service design and delivery. But, we've still got a lot of work to do to make sure that group are treated as equal partners in all scenarios. And then on the second point about our understanding, and by this I mean basically us as statutory organisations, I suppose it's a lack of understanding about how the VCSE sector could really help the NHS do its job better. And that includes me. So until I took on this role, I'm embarrassed to say that I had all of those misconceptions about the sector. So I suppose I thought really that the voluntary sector consisted of people in hospital wards, selling newspapers and sweets, a really important job, but that does not reflect what the sector is all about. I didn't appreciate that the sector is actually full of professionals who have specialist knowledge, who have expertise, really deep connections with communities. And actually, the VCSE sector runs small organisations that are really like small businesses. So, they need HR departments, they need laptops, they need office space, all of the infrastructure that we need to operate, the VCSE sector needs too. And finally, I suppose, it's the huge contribution that this sector kind of makes to the health and care of our local population. It actually forms a big part of the workforce. So just to talk about the third challenge, it's about our inconsistency. So we have been good at investing in the VCSE sector, but really it's been pilots and short-term projects rather than long-term investments, which would really support the sustainability of the sector. So that can be difficult for us as statutory organisations, but this is what the sector needs. They need routine investment and certainty, because in many cases those organisations are quite fragile. And then the other sort of half of consistency really, or inconsistency, and I am to blame for this more than anybody, is the dipping in and out of engaging with the sector. And to be honest, it's usually when we want something. So we go in and we have conversations and then we come out again. And what we actually need to do is walk alongside the sector and have those continuous conversations. So I'm going to hand over to my colleague, Sarah, who's going to talk about some examples of how the sector has improved the lives of local people in ways, I think, which the statutory sector, we simply could not have done.
Thank you. Thank you very much. That was amazing. I don't know how to follow that. But indeed, the sector is so diverse. And as you know, we've got more than 5,000 voluntary sector organisations in South West London, and about half of them are registered charities, so registered with the Charity Commission, and the other ones are constituted community groups. So the three examples I've got for you, one is in slide, is it 38? It's around social prescribing, which I know we are all familiar with, and I truly believe that it works at its best when it sits within the voluntary sector. So in South West London, you would have Merton Connected and Royals in Richmond, employing a team of social prescribers, or link workers, as we used to call them, based at GP practices, having conversations that are not medical with residents. Whether it is about referring them to a knitting club for their social well-being, or it is about referring them to a yoga class run by the local faith group for their physical well-being. Another example I've got in the following slide, which is about the ICB Priorities Fund. You probably recognise some of the projects, and the first two are led by the sector. So I was really pleased to see that Jigsaw for You, which is a Merton-based charity, got some funding from the ICB Priorities Fund. They will work with children aged 5 to 9 who experience domestic abuse. So the children will be supported to kind of elaborate on the trauma and find coping mechanisms for themselves and their families. And the parents will be supported as well as part of the project. The Health Inequalities Fund, which is in some examples are on the following slide, because of its nature, managed to give much more funding to the sector. And actually, most of the projects funded by the Health Inequalities Fund are led by the voluntary sector. And from these ones, I would mention Merton Men Cup. So they will support carers of adults with learning disabilities and autism. in moments of crisis or transition. And they will also offer them a network, like a peer-to-peer support group, but also allows them to shape services and have a say in the way services are provided. So it's all about kind of living better, increasing resilience, creating a connection with services, and kind of touching on those health inequalities we were talking about.
Okay, so just to kind of touch on the health inequalities bit. So I think the VCSE sector are totally vital in helping us reach those communities that face health inequalities. So if you look at slide 42, I think the difficult truth is that there are some communities that don't trust the NHS and who don't want to engage with us. And they have their reasons. However, it's these groups that are often the most marginalised with the poorest health outcomes. So we have to make sure that people in these communities can access NHS services, like immunisations, like early intervention mental health services, like screening services, so we can prevent that ill health, treat illness quickly, and if we can, avoid hospital admission. So this kind of makes sense for the health of our communities, but it also makes sense for kind of NHS productivity. So if we're going to do this, we have to make sure we design services and adapt services closely with our communities to make sure we act on their feedback. But I guess the key question is, how does the NHS get feedback from people who don't want to talk to the NHS? Well, this is where our small grants programme comes in. So if you go to slide 44, we've got the answer. So this is basically our small grants programme. We trialled it last year. We're kind of moving forward with it again this year. So I won't go through the detail, there's kind of 7 stages, but essentially we work with service leaders to identify priority topics and a focus on a particular population. So, for example, the topic might be MMR vaccinations, and our particular population group might be parents of children under 12 in kind of deprived parts of Wandsworth, for example. We gather insights and we share information on services. So we work with the VCSE Alliance, with Sarah and co, to offer small grants, essentially a few £100s, for VCSE organisations who work with and who are trusted by these communities to design events they know that these communities will be interested in. Because, let's face it, no one wants to come to an NHS event, do they, to talk to someone like me with a clipboard, asking very direct questions and wagging my finger about this is how you use NHS services. People are just not going to come to that. But people will come to, yoga sessions for the over 75s in a shopping centre. They will come to, English as an additional language. People will come to, cooking sessions at food banks, talks on managing personal finances, festive and religious events. So the VCSE organisations, run these engaging activities for the communities that we are trying to reach. And sort of along the way, they'll sort of talk to people about their views and concerns about health services, and at the end of the session, the community leader will share information about NHS services and have some good conversations. So we get a good two-way flow of information, and in a small way, we are contributing to supporting this vital VCSE sector that in turn supports our communities so well. So on slide 45, you'll see we are trying to respond to the VCSE sector, their need for certainty and enough time to plan ahead. So what we're proposing from now is to run 3 kind of grants programs at fixed points every year. So a winter program, a spring program, and a summer program. And I'm hoping that members of this board will allow me to bring those insight reports from our communities that experience health inequalities to your place committees and other decision-making meetings, because I think it's important that we get this feedback and it helps us inform our early thinking, our planning, and our priority setting. So I'm going to hand over to Sarah again, if you go to slide 47, who's going to explain the role of the VCSE Alliance in supporting these grants, and then we'll just finish with a few examples of where these grants have worked well.
Thank you. And, skip to 48 instead. I think actually the mechanism that Charlotte was just talking about, I found it really good for voluntary sector organisations, especially the small ones. And I'm really interested in hearing from anyone, any further partners who want to join in with this idea. I think it worked well because the Alliance managed to utilize existing structures. So the Alliance Leadership Group has the 6 CEOs of the infrastructure organizations from each borough. And these infrastructure organizations support local voluntary sector groups that have done so for decades. So they know them very well, they're very well trusted. And what we did is go through them to kind of in one go to get the information out there. And we were overwhelmed by their response, actually, especially with the Winter Engagement Fund. The leadership group as well has 6 experts, what I call experts, is 6 CEOs from voluntary organizations, 1 per borough, that has a particular expertise of area of focus. So, and we try to put it in line with the ICP strategy priorities. So you've got, for example, Sound Minds for mental health in Wandsworth, or you've got young people and children in Merton. We've got Tooting Football Community Club. So they come with that expertise on the leadership board. And the way we kind of channel all the views and expertise of the voluntary sector across South West London, at least we try to, is through the different networks and forums that these infrastructure organisations lead on in their boroughs. So you will see the green part has a list of voluntary sector forums that are meeting regularly and are led by the infrastructure organisation. And another, I think, benefit of going through the Alliance with the Small Grants Programme was that we were able to make sure that the payments and the kind of logistical aspects of applying for funds were kind of easier maybe and faster than it would have been through the NHS. And my last slide is about, well, I try to give you a very brief summary of what we've done, and there is so much missing anyway. And Charlotte will talk a bit more about grants, but I would like to focus on mental health. So we had an event in March in collaboration with the South West London ICB mental health team, and it was attended by about 60 mental health organisations, and we brought the feedback back to the South West London Mental Health PDG, Partnership Delivery Group, if I can remember the name correctly. And it was a fantastic discussion, actually, around enablers to do with making sure we enable the voluntary sector to be equal partners, as Charlotte was saying. And groups came up with a range of suggestions and points, mostly, of course, around commissioning and funding, but also around partnership and collaboration in general. So we've done that. And we're also working with Vanessa to look at how the mental health providers collaborative could involve the voluntary sector in a systematic way, which at the moment, as you know, has LAM and St George's Mental Health Trust on. But, you know, we would love for the voluntary sector to be part of it, and we're looking at different ways to do that. So a lot of work and more, and I've got a presentation that is more detailed as well, if you want, about the work of the Alliance this year.
Okay, thank you. So just to sort of end.
That's a long one.
20 seconds.
Yeah.
Oh, there we go. Brief intermission. So just to end with, I suppose, at the end of the pack, you've got 4 examples of where the VCSE grants programme is really working well. So if I take you to slide 52, beautiful photos there. That gives you a flavour. And really, you know, we had 7,000 conversations with our targeted group across, you know, 6 boroughs about how to access urgent care over winter. So really good conversations about pharmacies, about 111, about, you know, the NHS app, early intervention mental health services. And we heard some really valuable feedback in return about how we provide services, and also really importantly, how we communicate how people should use those services to help us coming forward, you know, for this winter. So we shared all of this learning through our engagement assurance group, brilliantly chaired by Mercy. And as a result, as you can see on slide 54, the Cancer Alliance then kind of replicated and built on this grants programme to gain valuable insight from communities, again, who experience health inequalities on cancer screening and cancer services. So we really are kind of sharing that best practice. And then on slide 55, Dr. John Byrne, a great supporter of community engagement. John is supporting our MMR grants programme, so connecting with community groups who can reach parents of the under 12. So, you know, just using kind of stay and play activities and in different languages. So, you know, there's a toddler dance group in South Norwood. You know, there's outreach sessions at food banks. There's arts and crafts for the under 5s in Mitcham, just so we can have these good conversations. And then finally, Mark, another brilliant supporter of community engagement. Mark, you've done loads of work with the VCSE sector. So, and these two examples are collaborating with the sector in Merton as part of the place priority to encourage physical and social activity, with a focus on communities experiencing health inequalities. And I think you've learnt a great deal from that. And then a similar approach working with young people in Merton and Wandsworth again to get into those communities and really hear what their concerns and views are. So that is the end of our slide deck. And I think, Mike, we were on page 59. We were asking the board 3 questions, so to kind of reflect on the progress that we've made. And really, is there anything else you think we should be doing to address these challenges? And how would you like to be kept informed of the progress we will hopefully continue to make?
Brilliant. Thank you for that. That was a whistle-stop tour of what is a huge amount of activity. And it's really good to see how we've shifted the dial on engaging with our communities in South West London. That said, there may be other ideas that people have that they'd like to raise at this meeting in terms of how we go further and faster in this space. But first of all, any comments, any points that people would like to make? Mark?
I think it's probably 3 things, just to endorse the trust. So actually, when we're talking about communities that are marginalised, it's often the trust that will get them into a service. I think it also is about co-designing the solution for those people, and it's not just about we've listened to you and then we'll put an NHS solution in. It is about co-designing. And then finally, these services can be the conduit into more traditional health services. So if we look at the example, in Merton, we've co-designed an activity programme through gyms with people with learning disabilities in SEND. That also enables us to hit our LD health check target, and it's actually making that thread through to the more traditional targets. So it's just very supportive.
Thank you for that, Mark. Vanessa?
So, so thank you for all the work that you've done so far on mental health, and obviously we're really, really keen for it to continue. And I think it is really important as we establish the provider collaborative that we have you as equal partners with us. So I look forward to working that through. One of the things that I think we need to be really thoughtful about is how we support all of the aspects of the third and voluntary sector, and particularly those organisations that support our black and brown communities, because I often hear it played back to me that a number of those have been closed during the pandemic and are less represented in the group that we have here, if that makes sense. So how do we make sure that inequalities within the third and voluntary sector are also addressed to give us the greatest reach into the organisations? And then my last point, I think it's really great that the idea around engagement and how do we do that from a place of building communities' trust on strength rather than naming all the challenges that we have. Does that make sense? Because I think it's really important that we build that community strength in the NHS, as well as us hearing some of the challenging feedback.
John?
Thank you, Chair. Just to pick up on points made about... Oh, thank you very much for that. Just to pick up on the point made about trust, particularly when it comes to vaccinations, whether it's mumps, measles, rubella, whooping cough, whatever it might be. Many of us in the NHS are rational thinkers. So we might think an immunisation is a rational thing to do, it's a good thing to do, but other individuals and communities may not feel the same strength of rationality that we do. I'm not saying they're making irrational decisions, they just don't see the same rationale that we do. And by using this approach, there is the opportunity to listen and also to have different conversations. But you can only have a conversation after you've listened to people. And once you've listened to them, you have a better chance to explain. And the size of the gap we've got to fill just in immunisations is we're about 87% now in South West London, which is pretty good compared to the rest of London. But the rational fact is we need to be hitting 95% to get that infamous word now, herd immunity. So we're talking about marginal gains here. And when we look across our 6 boroughs, the population groups that we're trying to reach are actually different. And it's not just based on deprivation or ethnicity, it's actually deeper than that. So Richmond may not have the same deprivation or ethnicity challenges driving low uptake compared to somewhere like Wandsworth or Merton. And it's through this engagement approach that we can perhaps bridge some of that gap and slowly but surely build up the numbers. And it's just on the numbers that there is a temptation to go, well, 7,000 conversations, just how many vaccines extra did you give? And we can't necessarily prove that. And that's always going to be the challenge. So we'll know the value of everything, the price of everything, but the value of nothing. Because this trust piece does take years and years to build up, and we can lose it in a flash. And we saw that with COVID. So I'm an advocate for it because it works. And it's the kind of thing we need to invest in. But investing in it, understanding is that it's not like counting a hip operation, a cataract operation, or some other novel intervention which we dream up.
Jacqueline.
So I was sort of thinking about the fact that we do in acute care, we count widgets or things that we do, and so we know the outcome of that often. And I'm sure there's a lot of what you do here it's tried and practiced elsewhere. We know it has a positive intervention because we've seen it over many years. Is there anything that you're doing, Sarah, that you don't think anyone's done before that you've done in partnership with with our local communities that we haven't actually proved one way or the other, but you might need some help to say that actually it has got good outcomes, whatever those by the local population are determined to be? Innovation, I suppose I'm asking.
I'll start with your question then and then go back to the others. There is plenty within the voluntary sector. If you're talking about projects within the voluntary sector that are, innovative and have worked, there are plenty of them. There are definitely plenty of them, and that we could work on and kind of pilot maybe across South West London. There are some brilliant examples. I'm not going to name any of them, but there are some brilliant examples out there. So it's definitely something we can have a look at. And it was one of the suggestions, wasn't it, from the mental health event actually, to look at best practice cases and maybe kind of see how they could be rolled out. So that's something we can maybe explore further. That's good. And
because I think a lot of the sort of innovation which you're talking about is based because the voluntary sector is small and agile. So I think often, we kind of, in the NHS, and have been as guilty of this as anybody else, is kind of, we've got a problem we need to fix, we're going to describe the problem, we're going to put a financial envelope around it, and we're going to say, voluntary sector, what can you do? Can you come back next Tuesday, 4 o'clock, with all your solutions? And I think if we give the voluntary sector more time, and actually what we found really helpful is just, and Mark, you're really good at this, is describing the problem, having a conversation about these are some of the problems we're facing. What do you think you could do to help us? So if we are less prescriptive, more open-minded, but that really relies on us doing it upstream. So, we've got a joint forward plan now. We know what the plan is for the next, 5 years. So if we can get in that space where we think ahead, we plan ahead, and we just have some good conversations, and we take the formality out of it, which was what Mercy was saying at the beginning. It's about relationships and saying, do you think you could do this? Because often they'll know somebody who can help because the sector is so diverse. And often, it's really good value for money if you go to the voluntary sector just because they're smaller and more agile.
Jonathan.
Thank you. That sort of builds on what I wanted to say, which is 7,000 conversations is obviously a lot of rich conversations that you've had through this experience, and we invested less than half of 1% of our winter monies to focus on this, to give some people some idea of scale. And it's really an offer, I suppose. It'd be helpful to come back, I think, to the Urgent Emergency Care Board, so making this offer on behalf of Matthew and myself, to share what is emerged from those 7,000 lessons that we need to build into our plans for the winter coming, because that's work that's already underway and very live now. So it's good to see it. I think we need to make this ongoing commitment for the winter ahead, so we can deliver what we need to for the winter ahead. But it would be really helpful to inform the views of the Urgent Emergency Care Board and the 30 people around there. To have another 7,000 friends would be really helpful, wouldn't it? So, an offer.
If I can come back on that, Chair. What a marvellous idea. Thank you, Jonathan. We've just actually finished our evaluation report for the Winter Engagement Programme, and there is so much good stuff in there, you know, really good nuggets. I put a couple of examples in the paper, but I thought, well, I'll just give you the link. But yes, that would be brilliant. Thank you.
Can I add something? Yes, absolutely. And I think if we look in perspective at how much funding, how much of our investment goes into the voluntary sector is relatively small, but the voluntary sector, because we are so flexible, we are so innovative, and we work, you know, across the board in collaboration, we can do so much more, you know, with small amounts of money. We can really capitalize. And as you've seen from other slides as well, we can bring in external funding as well. So whatever funding comes from the NHS is actually building on existing infrastructures and can be really utilized, you know, at best. I wanted to add on your point on co-production, because co-production is so important, not only for new services, but also for existing ones. And one of the things that our commissioned voluntary sector groups have told me is that it's so important to make sure that whenever you want to review a service that they're already delivering, you know, you engage with them early, quite in advance, into the, you know, before the tender takes place, before the service specifications are written, because what we tend to do sometimes is kind of, you know, because of the timelines, we write the service specification for them, and then, you know, you've got such a short period of time to come up with a proposal that maybe wasn't really needed in the same shape and form. But yes, I think co-production is so essential, and communication as well. I mean, continuing to communicate with the sector and those providers, whether in a formal or informal way, really makes the difference.
Thank you. Nicola.
Thank you. So yeah, really important work. Thank you for everything that you're doing, and just kind of in the interests of that kind of early involvement and looking to the future. So we're really busy in primary care right now, looking at ways that we can integrate our working with community care and social care, and work in these integrated teams. And I think as we evolve that, it seems very, very important to get the involvement and interface right with our voluntary and community and social enterprise organisations. And just to kind of think about that and how we can start really getting some constructive ways forward on that, because I think that primary care particularly, there's a lot to be done with our kind of, you know, common clientele, with our residents, our patients, and we're often looking after the same people, but not always. And I think this might be a really good way to get people that are being served really well in the voluntary sector, but to bring them and engage them into health and care services in the kind of more traditional sector. I think we've just really got to work out how we can do that effectively together.
Brilliant, thank you. Mark, quick point from you, then I'll come to Karen.
So it's just picking up on Declan's point about innovation. So if we looked at the, builds on Nicola's point about the Battersea to Brazil model, where we've got community workers knocking on people's doors in 2 large estates in the Doddington, and then the supported by the PCN and the GP, yeah. So actually, it's about that engagement and bringing those people back into kind of the health service, so that we are quite innovative, and that's the crossover borough.
Yeah, I agree, and I think we've got in primary care some very good examples of collaboration and partnership with the sector, and obviously everyone knows about social prescribing, and we heard, about that particular project as well, and they're working really well. And I think what we need to do is learn a bit more from what is working, and maybe see where else we can, collaborate. So yes, would really welcome any discussion around that.
Karen.
Thank you. So you talked about trust and everybody picked up on trust. I think I'll take a number of other things away from the presentation, including partnership and new approaches. I've been here about 7 years now and it's just all flown by. But if I think back to where we were with the relationship with the voluntary sector then and how far you've all come, I just wanted to congratulate both of you and all of the teams that are beyond, and also place teams and all the work that they do. And we have collectively got a huge way to go, haven't we, if we're going to continue to meet the health needs of the populations, but it shows the really strong foundation, so kind of trust and partnerships and new approaches that you've all brought. If I see the difference in the travel that we've come to, I just wanted to say congratulations.
And you did ask us some questions. I think you've had answers to the first two. In terms of the third one, my suggestion, which I'm hoping the board will agree to, is that we have an annual report from the VCSE work. Clearly, that will not be the only time we talk about the voluntary sector, because I think we talk about the voluntary sector, hopefully in most items, but actually showcasing it at least on an annual basis. I'm going to go for final words to Mercy, who is our non-executive sponsor for this work.
Yes, and bringing it back to my committee, really. So a lot of the comments that are being made is what we kind of deep dive at in the committee. So we get feedback, we look at where we can take learning across the whole of southwest London as well. So those amazing projects that we hear about, we're always interrogating what have we learnt from this and where can we spread that good practice. And I just want to encourage people from their own collaboratives and their own trusts and things to make sure people come to those meetings, because it's a really important way to learn and to share.
Thank you, Mercy. Thank you both very much for your presentation as well. I think you can see from the richness of the discussion that you've inspired us all. So that means, Helen, you have the challenge of keeping our energy levels up as we go to the infrastructure strategy.
I'm always up for a challenge, thank you. I wanted today to talk you through the infrastructure strategy. I think historically in the NHS, the estates have been managed individually by individual organisations that have owned them, and actually looked independently at what they've got. So we've not really worked together as a partnership to really start to bring things together. And as an ICS, we really have a role as an anchor system, and to be able to support the whole system and our communities to be able to go on that journey. And therefore, it's really important that we start to move away from what we would have traditionally done as an estate strategy on that journey and move more towards an infrastructure strategy, really bringing the links out of the enablers between estates, digital, sustainability agenda, as well as the workforce, and enabling our workforce to really be able to deliver for the health and well-being of our population and really provide high quality care as we go forwards. So I think we've been on a journey on part of this. We've started from a decade ago where individual organisations were looking after their own estate, to the CCG having a strategy around the system for estates only in 2018, and then this is the next step on the journey. So as part of that, in March 23, NHS England, as part of the operating guidance, asked for this infrastructure strategy to start to be developed at a system level across the whole country, with the aim that they are going to build that into a national infrastructure strategy for the NHS. And they're going to take that, bring back the learnings they can see from the individual 42 that they bring together, and look at what the links are, the commonalities, how we can look to address these things as we go forwards, but also really use it to look at what funding in the NHS is required to take us on this journey as we go forwards to enable better care and access. So the requirement was to develop the strategy by the end of July, which is why we are here today with the strategy that we've worked with our partners on it Also, I think it's really important that we have got a role here as well, along with the GLA and other partners, about how we try to make London the healthiest global city in the world, and how do we play our part in all of that. And as part of that, London are therefore updating the London Estate Strategy with the GLA in 2025. So again, this starts to feed into that, and what do we look like and how resilient are we, recognising the climate change, etc. So we're starting to look at how all of that brings everything together as we go forwards. So it's really important that we've taken what we've had previously to build on it. We've taken the digital strategy that you've already seen at the board and brought things together with our partners to try and develop this going forwards. So effectively, the strategy starts from a gap analysis. So where are we now? What is our vision and where do we want to be? And what is the journey to get there over the next 10 years, and what does that look like? So if I think a little bit about where we are now, between our acute, community and mental health trusts, we have 164 sites that we're delivering services from. 52% of those predate the NHS. So that is an ageing estate that we have from that point of view. If I look at the GP sites, we have 198 sites across South West London. Again, about 47% of those are GP owned, and about 44% of those again predate the NHS coming into place in what we do and what that looks like. So we have a challenge of an ageing estate, and how do we look and support it and make it modern for modern healthcare and how we go forwards. But we also struggle with some other challenges at the moment. So we've obviously seen that the cyber attack in South East London took place more recently. So how do we ensure that we are digitally secure as we go forwards, as we use that as an enabler to take us forwards and improve access for the population to what we do, and make sure that we're focusing the workforce on doing the right jobs and roles, but using digitally enabled services. How do we compete with the private sector for our scarce workforce? Our infrastructure workforce is really quite scarce to attract. It's much more better in the private sector and where they are. And so actually, how do we look at our communities and local people and say, why come work in the NHS and support us with our estates and our digital as we go forwards, and how can we do that? We have got high energy costs in what we're doing, so how can we help ourselves become more sustainable? As a system, we've already looked to try and get grants to do some of that work, and we will continue to do so from funding outside the NHS, but how do we take that step forward change? And how do we really work together with wider partners to utilise our space better, instead of looking at it just for our own needs? And how can we really support ourselves so that we've got the right services in the right places for our community, so we can get in and reach those hard to reach people in what we do? Saying that, we have done a lot over the last few years. We've made significant investments in what we have. If we look at our response to COVID, we've really invested in our infrastructure and what we've done to be able to adapt to the changing world. We have got new community, primary care and mental health estate that has come online in the last few years, and we've got new community diagnostics that have been set up. And then if we look to a digital world, we've looked to create our own care record and to translate that into the London Care Record as we go forwards. And our uptake of the NHS app as a new front door into the NHS. We're doing really, really well with the highest level of uptake in London, over 62% of the population over 13 in South West London taking up the app. And they're using it. They're really using it. Since April 23, repeat prescriptions usage on the app has gone up by 98%. That's really high in where it's gone. And the monthly logins have increased by 89%. So it's not just somebody has downloaded the app. We're using this as a way of working as we go forwards, which is how do we really take that forwards as we go. So we've looked and worked with partners about what our vision would be, and we came down to 3 key things. We wanted smarter, better health and care infrastructure. We want stronger, greener buildings as we go forwards, and we want a really fair, efficient use of resources. How do we make sure we start to address health inequalities in the way that we organise ourselves? How do we make sure that we are really utilising things well, we're opening up access, and that we're aligning ourselves to new ways of working and new pathways as they're being developed? So if we think about advice and guidance that the trusts are providing between themselves and the GPs, how do we really utilise that and enable that through what we do? How do those digital front doors work? How do we enable Pharmacy First to continue on its journey of where it's going to use things as we go forwards? And how do we work with our public health colleagues to really enable that and take it forwards to make it better for our population? So the document sets out those journeys and those steps and where we're going to go next. I think what's really important as we go on the journey now is how we start to embed the plan underneath that as to what we do and where we go, and how we work together closer with our partners to do that, how we really make one public estate really work for us as we go forwards, how we establish the underpinning plans, and that is digital and green and estates all together, and to do that to enable our workforce to be able to be the best they can be. How do we minimise the voids that we've got, make sure that the pounds that we have are really going on making sure that we're using estate where we need estate and that we're keeping it to the highest quality possible? And how do we focus on supporting our workforce? I will stop there and I'm happy to take questions.
A significant piece of work, I think, this, Helen, so thank you and the team for pulling it together. I think it's really interesting to see it all in one place, and like you, I was surprised by how much of the estate predates the establishment of the NHS, which does mean that we have some significant challenges. That said, over the last year, 18 months, I've seen some magnificent developments in, I'm looking at Callie here, in southwest London, including the new developments at Royal Marsden, which are truly stunning, but also Springfield Hospital, which again is a real jewel in the crown of southwest London, and a massive community resource for the people in Springfield. Sorry, Elaine, was your hand up? No, it wasn't. In which case, I will go to Callie and then James.
Thanks very much, Chair. So I've just had two quite different points. So I thought it was a fantastic piece of work, and a very necessary piece of work given the age of our estate and the criticality of that to patient experience and care. My two different points were, firstly, something on digital. And it came out of a conversation I had with the regional director earlier today. And it's just making sure that as we develop that timeline, we connect up between what's going on nationally with the development of the NHS app and, national initiatives to improve the quality of data and use of information by patients and staff. And then what we're all doing bottom up with our own digital health transformation systems. So if I take that back to the Royal Marsden, for example, we've got over 50,000 people now using the My Marsden app from our new Epic Connect model with Great Ormond Street. And we're just beginning to have the conversations about how do we make sure that's easy for patients and the public to navigate compared with what they get from the NHS app. So it's that connecting up between national and bottom-up initiatives to improve access to information for patients. So that's the first thing, just to build into the plan as we develop it, I think. And none of us have got that right yet. It's just, needing to do that. What was my second point? Oh yeah, the second point was just making sure we can draw a distinction between things that we have control over in our plan and that we're responsible for delivering locally, and things where we need government and other help. So it's drawing those connections, and CDL limits obviously being one. We've got a very ageing estate and the need to try and address that, and some of that is within our gift and our capability, but obviously we need support. And we need to be able to escalate those messages upwards, so we're providing, an ongoing translation of estate. But neither of those 2 points will be unfamiliar to you, Helen. But thank you for the work. Thank you, Chair.
Thank you. James.
I think, so obviously I partly work as the SRO for one of the biggest schemes that's sort of set out in the appendix to this plan in terms of building your future hospitals. And I know colleagues around me have recently delivered other major infrastructure schemes as well. I think just a lot of what is in here really chimes with what we are finding as we develop that scheme. So I think you don't just have an estate scheme anymore, you have an infrastructure scheme, and developing new projects is very different from maintaining some of, for example, some of our old estates. So we're having conversations about integrated digital, about smart estates, about integration of AI into future infrastructure that are very, very different than some of the conversations we have about sort of keeping the show on the road and trying to adapt older infrastructure. So I think there's a lot in here that does really chime with that. I think the AI is absolutely critical as well. So some of the conversations that we have been having about building your future hospitals have been about how we can integrate AI solutions into future infrastructure. And I think that public and stakeholder expectations around that, things working together, digital working together, places working together, space working together between multiple organisations are really high now. And I think that the way that we design infrastructure has got to really respond to that. I think that gets me probably into two questions that I think it would be useful to consider in terms of how we take this forward. I think as we look at individual schemes, because there will always be individual schemes that come forward as part of an infrastructure strategy, how do we use the strategy to test and refine and challenge those schemes? So how do we develop the framework around that as a board and as an organisation, as a system? I think also, how do we use this infrastructure strategy, particularly the parts around one public estate, to have really cross-sectoral conversations as well? Because stepping aside from BYFH with my Sutton hat on, I know that there are absolutely conversations
from that and think about actually how do we do it once and do it across in a way that really then enables us to go forwards. And I think that's a different way of working and thinking for us, and challenging upwards about actually, no, we could do that, but we need to think about it as a wider place and how we all come together and what we do. I agree completely about the one public estate. What we do have is an estates board, which actually we probably shouldn't call it an estates board anymore, that sits across the whole of South West London, but it does have digital on there, and it does have one public estate representation. So we've got the wider local authorities on there, so we can start to have those conversations, and we need to think about how we develop and evolve that further as we go forwards to enable us to really look at this as we deliver it.
So just a couple of points from me in terms of moving forward. Clearly, I think the NHS app uptake is superb in South West London. I was at a recent national event where Joe Harrison, the national lead for the NHS app, singled out South West London as an outlier in a good way, i.e. having the highest reach into our community and the highest utilisation rate of it, and much higher use of the different functionalities. It was really good to see Ian Frost present at the South London Health Tech Conference, our Ian Frost, on how we're using the NHS app to actually transform pathways, as well as just as an access point. On that, really important that if you have got the NHS app, you go into settings and you enable notifications, because that will mean that you get all of the functionality from the app, which its default setting is not to have that enabled. So please do that. A couple of points I would, and I'm sure this will be picked up by our colleagues from local government, but it would be really good to see reference to health in the high street within this, i.e. looking to where we can boost footfall in shopping centres by locating our health facilities there. They tend to have the best communication lines, transport lines for local communities, so it is sensible. And there are a number of commercial landlords of retail space who are very interested in doing deals with NHS organisations to fill vacant properties. So it's a way of mitigating some of the costs as well. I think further down the line, I'd probably like us to commit to a sort of bolder strategy about what we think should be on hot hospital sites and what should be on cold sites. I think it's probably too early to commit to that now, but we shouldn't be using very, very expensive hot sites for services which could be located in other places. I note that Manchester ICB has committed to taking all of their outpatients off hot sites by 2026, which would be bold and is potentially a cost-saving issue, something that we probably need to be looking at in the longer term. Certainly not by 2026, but longer term as we plan our estates. So just a couple of observations from me. Sarah, did you want to come in with final? Oh, sorry, Sarah.
Sorry, very quickly. Just kind of reinforcing the point that James was doing about cross-sectoral conversations, and I think one of the enablers that came through the latest event of the Alliance was co-location. So this suggestion of using estates for and sharing space between the voluntary sector and NHS colleagues, and where it happened, it really worked very well.
So, I'll go to Sarah now.
So thank you. It's really good to see this all brought together. I think that's really important for us as a board to be able to see this all brought together. And I think the vision is good and very positive for us in South West London, but I don't want to underestimate the problem that we have. I mean, what is really clear is the estate problem we have. I mean, it is fantastic actually on the digital and the use of the NHS app for South West London. That's all really good and we're all making progress on the digital side. But we have fundamental issues around our estate and actually treating patients in buildings that are not fit for purpose in many cases, and trying to see our way through that over a period of years. So it's going to be a really big and important piece of work for us in South West London to ensure that we deliver on this, I think. So it's really good to see it brought all together. I think there's huge potential here, but I wouldn't underestimate the difficulties that we may come across both with things like CDL funding and all of these things to actually get this done, as well as, and I will say it, politics, which, you know, people are very wedded to buildings often. Sometimes we don't need all of those buildings. Sometimes we might need to deliver care in a different way, and sometimes that is quite difficult. So, you know, we will need to think differently about this, but I think it's a really important piece of work. Thank you, Helen, for bringing it all together like this, and we'll have to think about how we take this forward positively.
So Helen, we gave you the challenge in presenting this of keeping us animated. I think you've succeeded. But we're now going to move on to item 6, which is the review of standing orders.
I really have no hope on this one.
Yeah, this is going to be your major challenge.
So I'm going to be as upbeat as possible. So it is really, really good governance to make sure that we review our business rule documents on an annual basis. And those documents are made up of the standing orders, the standing financial instructions, and the scheme of reservation and delegation, which basically shows the limits of how the delegations are made. So we have been through this piece of work and we've presented it to the audit committee, and they were recommending it to the board. And when we looked at the standing orders, we didn't identify any changes that were required. We felt that they aligned to the business rules and the ways that we were working currently in the requirements on public sector bodies. When we reviewed the standing financial instructions, the counter-fraud team also reviewed them at the same time and recommended a number of updates just to strengthen around fraud and requirements and what their role was as our counter-fraud support and where we should go. We also included a section on the new provider selection regime, which came into place on the 1st of January 2024, so we needed to update in line for that and what that looked like. And then we moved to the scheme of reservation and delegation, and we worked with our internal auditors to benchmark our limits and processes and governance across other ICBs to see how we compared and to look at good practice. And we came out very favourably in that, and we were congratulated by them on what we're doing and how we are working as we go forwards. But as a consequence of doing that, we have proposed a number of revisions. The first one is just to revise the limits slightly around the executive and the team structures on their approval limits, just to recognise the new management structure that we have put in place over the last few months. And then we reviewed the committee approval limits and recognised that we wanted to find a balance to make sure that the Finance and Planning Committee was doing the appropriate assurance role that it has for the board, not just business as usual, and therefore we're proposing a slight change to those limits so that more work is done as business as usual, in fact that that is what it relates to, and to make sure that we get that right. And finally, we have adapted our processes to better respond to NHS England's requests, where it asks the ICB to put letters of support in for bids that are made from partners in the wider system, to make make sure we are fleet of foot and can respond to them. That is a section actually that we are leading the way on, and other ICBs haven't put into their documents yet, but internal audit were recommending that was the direction of travel they should go in.
Thank you. Martin, Chair of the committee, the Audit Committee.
Yes, thank you. I mean, I would just confirm that we, at the Audit Committee, we did go through the scheme of delegation, standing financial instructions in a reasonable amount of detail. We also looked at separately at the benchmarking against other ICBs around London, and we were happy with the changes that were proposed. It was great to see, it was good to see that we were in alignment with other ICBs, and I would say from an audit perspective in a better position than other ICBs in terms of what's proposed. So we're happy to recommend for approval.
So, as a board, we have a choice. Would you like to go through line by line, or are you happy to accept the Audit Committee's recommendation? I will take it as that we accept the Audit Committee's recommendation. Thank you very much. Thank you. We'll now move on to terms of reference. Ruth, you have a similar challenge in terms of approving changes to the terms of reference for the Remuneration Committee.
Thank you. So I think these are relatively straightforward. They were just items of clarification, which are summarised in the exec summary. So removal of nominations from the committee's title, remove the committee's role in agreeing the creation of B9 posts, clarifying the role in performance appraisals and the role in approval of board members, and strengthening the role in approving pay-related bonuses to VSMs.
Are people content with the recommended changes there? Thank you very much. So we will now take a comfort break. So as you know, we've been engaged in a lengthy process of planning over the last few months. I'm now going to ask our Chief Operating Officer, Jonathan Bates, to present our operational plan for the year ahead. Jonathan, over to you.
Thank you very much, Chair. So, as you rightly note, it's at least 6 months of hard work. So, we're going to start by acknowledging all the work of everyone in this room and many beyond who've got us into a good place for our plans for the financial year that we're currently in. We submitted our final plans on the 12th of June to NHS England, and I'm pleased to say we received a letter from them on the 4th of July confirming their support and endorsement for the plans that we have submitted. So it's really coming here following previous discussion back in May for final endorsement of the proposals for the year ahead. So I think it's probably just worth speedily walking through some of the key areas in the paper. So working my way through it from the beginning, as it were, that guidance was issued later than usual. It was issued at the end of March of this year, and it covered those 6 bullet points highlighted under section 2, the background about what we were expected to achieve and deliver, and they will be all common themes that are familiar to people around the table. Our approach to planning has, as I said, really been since the turn of the calendar year to think about some of the core assumptions. So, for example, our approach to achieving timely access to care for patients for elective care and for cancer waits was agreed by the Elective Care Board all the way back in January of this year. The Urgent Emergency Care Board made some key decisions on delivering the 78% performance standard in March. And there's been various discussions through the Finance and Activity Committee and other committees to land the financial assumptions as well. The governance and oversight is set out in section 4 of the paper, and board members can see all of the groups that have been involved in making the key decisions that we've had to make. In terms of activity and performance, we've tried to sort of summarise those in a couple of tables. So South West London has a strong track record of delivering on timely access to care for patients for planned care, and you can see that set out in the tables, and also in relative terms a good performance on urgent emergency care too. So you can see that. There are a couple of areas around diagnostics and overall general and acute bedded capacity which remain amber, linked to some of the pressures we face and some of the triangulation we've needed to face as a system with our financial challenges, amongst other things. For mental health, you can see again most of the targets are green in terms of what we're seeking to achieve. The two that are not, one relates to out of area placements, which is an ongoing challenge for both our mental health trusts, and this specific number relates to that for South London and Maudsley, and the perinatal mental health standard, where our birth rate has fallen substantially. So there's some sort of definitional issues with NHS England about the standard that are probably worth noting. But other than that, we plan to deliver those key targets around mental health and learning disabilities, which is good for our population. And then in terms of other targets, we're also planning to deliver those. The exception being that the GP appointments seen within 2 weeks suddenly moved from 92% in previous guidance to 100%. So we've yet to develop the full plans to deliver 100%. So we've focused on continuing to deliver the 92%, which is again an increase of 3% in appointments planned over the previous year. The financial challenge, I'm sure Helen will want to say more about this, but the position notes the £120 million deficit position recorded for the system and the non-recurrent funding to support that to achieve a balanced plan. The additional pressures that places on us from both a revenue and capital point of view, because it's a loan and having to pay that back over the years ahead. So I'll let Helen talk about those in a minute. And then on the workforce, you can also see the scale of some of the financial challenge on our plans around whole-time equivalent staff, which is a key deliverable for the year ahead. So in terms of key risks, there's obviously the ongoing and daily, if not hourly, operational challenges that so many parts of our system face, the risks that's further exacerbated by industrial action, the risks of achieving our financial plan at the scale as set out here, the risk of making the required changes in workforce that we need to deliver, and the key risk around the delivery of our transformation programs at the pace that we need to secure. So an example, given the length of stay reductions that we've signed up as a system around reducing length of stay for urgent and emergency care patients by 1.5 days, which is really a great thing for those patients, staff, and for the system if we can achieve it, but is a really significant challenge. So that's an illustration of the further transformation and productivity programs that we need. So I think that's probably a quick whiz through the key components of what we've sought to secure over the last number of months. I'll probably hand over to Helen to see if there's anything you wish to add in addition, and as I said right at the beginning, to note that this has been agreed by NHS England now, and of course we're already in month 4, so we're busy delivering it.
Thank you for that. And yes, if we go to the financial plan now, because they're two sides of the same coin.
Thank you. Thank you to wider partners for working together. I think it's been a really difficult time for the NHS during this financial planning round, such as we got to a point where NHS England worked through the level of funding they had and issued control totals out to systems, for which our control total was that £120 million deficit. We've worked really hard together as a system to come up with plans around how we would look to mitigate that and to be able to deliver it. And so agreed with NHS England to the £120 million deficit plan. And as such, as Jonathan said, that has then enabled us to receive fixed block funding to support that non-recurrently. In doing so, within that, we've agreed to delivering the management cost cap for the running of the ICB, to reduce the level of agency expenditure to below the cap that is set by NHS England, and to ensure that we meet the mental health investment standard, which is an uplift of 4.2%. Also within the plan, we have worked really hard to minimise our impact of inflation, but recognise where there are impacts that are over and above those that are in the national NHS uplift, and therefore recognise that we need to fund those as we go forwards. And we've looked to minimise any cost pressures across the system. That has made it required us to have a £257 million efficiency target for the year, which we are working towards and delivering now as we go forwards. And also within that, we've assumed that we will deliver ERF, the Elective Recovery Fund, so additional planned activity over 5% over the target that's set by NHS England through productivity gains rather than paying for additional sessions and work to be done. So there are significant risks into delivering the plan, including inflation and being able to manage the non-elective pathways and support in winter to maintain that elective capacity and the delivery of that large savings programme as we go forwards.
Thank you for that. And this has gone through all the appropriate governance. I know from having spoken to Dick, our previous Finance and Planning Committee chair, that he was happy to endorse this plan. And I've also spoken to Anne, the chair of our Finance Recovery Board, and she's happy to endorse this plan. Helen, it might be worth drawing out some of the penalties that we face as a system in deficit, particularly around capital.
Yes, thank you. So within the paper, it does outline that as a consequence of having a deficit plan, there were reductions made to people's capital budgets across the country. For South West London, that is a reduction of just under £10 million worth of capital. So at the moment, we are working through the detail of that and what that means to the schemes that we have, but we are not looking to affect anybody's backlog maintenance. We're looking to ensure that we maintain our safe sites, but we're looking at how we stagger programmes of work that we do to be able to live within the envelope that we will have.
Thank you for that. Just sort of a note, I'm not expecting you to have the figure in your head, but it would be useful in future when we're looking, when there are tables presenting the deficit position of the trust, for that to also be expressed as a percentage of the turnover of the trust, because the crude numbers suggest that all of our trusts are the same size, and they're very, very different sizes. And some of the challenges may not be as material to the wider system, but actually signify quite significant financial challenges within that particular organisation.
Yeah, happy to do that. We look at it that way when we look at it at the committees, etc. So happy the board sees it like that as well.
Great, thank you. Any comments on this, or are people content to endorse the plan and note the thanks to the teams here, but actually the teams across South West London in all of our trusts? Thank you. We'll move on to an update on workforce. Karen.
Thank you, Chair. So we've talked in the board, in seminars and in these meetings, we've also talked across the Health and Care Partnership about the workforce challenges that we face, and we wanted to bring you an update on some of the changes in relation to our workforce, but also an update on some of the South West London-wide initiatives that we work on together to try and address some of the workforce challenges that we face. If we look at slide 222, I just wanted to reiterate that our workforce challenges remain unchanged. You will know them, certainly those of us that are working within provider organisations. Recruitment for some of our vacancies remains challenging. Planning the workforce of the future and the capacity and capability to do that is a challenge. Equality, diversity and inclusion, eradicating racism remain things that we have a priority to address, as well as retention, looking after the people who so well look after others. The low workforce morale, and also then delivering workforce transformation while we are dealing with the operational pressures that Jonathan has already outlined. So in terms of the headlines on slide 223, the NHS in South West London employs just under 34,000 staff, and we are seeing progress. So we are seeing reduction in turnover. Although turnover for us is still 0.5% higher than the London average, we have seen a 2.4% reduction since April 23. We're also seeing reductions in sickness levels, so nationally standing at 4.9%, and in London 4.4%, and in South West London 4.2%. So we are seeing some improving workforce positions. But we remain challenged, as I've said, and you'll see as we go through some of the things that we will be dealing with and trying to work through. But as just we've already talked about in the operating plan update, we've also seen significant increase in numbers of staff across South West London, and that creates a financial pressure that we are all aware of. So I wasn't going to go through the slides in huge amounts of detail, but just to say, I mean, if you look at 225, the difference in turnover, you'll see that we are seeing significant trends down in line with London and the national average, but workforce turnover good. Absence data, we have 3 main causes of absence: musculoskeletal, minor illnesses and mental health. And as we go through the rest of the presentation, hopefully you'll see that some of the health and well-being priorities that we are addressing are also addressing those areas. So the majority of those down on since 2019, with the exception of minor illnesses, which are up. We've seen changes in the workforce, and we've just broken that down in terms of staff groups on 227. We can also see, in terms of our gender differences, some challenges that we face as we move up towards the higher levels, and how the changes in females and males comparisons begin to change as we move forward up into the scales. Ethnicity, there are some graphs there. To be honest, this graph appeared when I was on leave. I'm going to just go on to that because there's a discrepancy in some of the data, but I'll come back with what we know. But if we look then at how we are trying to address the challenges that we face, if we move on to 232, the board will have seen this visual before. There are 4 main areas of transformation programs. We're looking to attract, retain, develop and transform our workforce, and a number of the areas that we're working on across South West London are designed to do just that. So on 233, you can see that we have an evidence base that shows that actually those 4 areas are the right areas to focus on. And you can see some of the areas, some of the ideas that we are doing together, both at South West London team and across with our chief people officers. So if you look at attraction, we're looking to change the way that we advertise. We're looking to streamline and simplify recruitment. We are looking to make sure that we've got health and wellbeing offers that support our workforce across primary care and within the NHS. System-wide retention, and also then looking at how do we begin to transform our workforce, and what is it that they want and need as well, and how do we think about things like apprenticeships differently that we've talked about in this board before. If we go on to 235, we are trying to, as I said, look very differently at how we recruit. So trying to create very different material and information that is readily available for people to consider the NHS as an employer in a different way than we have been before. Looking at engaging with communities that often don't consider the NHS as careers, thinking about much more in-reach into communities and how people can use transferable skills to be part of the NHS in the future. 236 just talks about how we're trying to transform the way that we write adverts. We're trying to use less of NHS jobs because you need to know it and you need to have particular ability to be able to manoeuvre it. But we are working, particularly with South West London and St George's, on recruiting very differently. So holding careers fairs, I'll come back to this in a second, but holding careers fairs that have very different interview processes, have very different selection methods, to begin to make sure that we are changing the way and making it much more easy for people to find a role within the NHS. 7 shows you the range of social media information and material that we have developed to make sure that we're taking away the old style recruitment and trying to make connections into people that may well have not previously thought of the NHS as a career, and you can see some of those images there. If we think about trying to make it easier to get a job within the NHS, and this is 239 now, so thinking very differently about how we run careers events, etc. So We ran an event with South West London and St George's. We saw 170 people attend that event. We took a different approach to interviews, so meaningful discussions, tried to get how do you get transferable skills rather than answer specific interview questions. Out of those 170 people, 114 people considered as part of a meaningful conversations, and of those 93 people were offered on the spot job offers, and you can see how that broke down in terms of healthcare assistance, etc. So a very different way of connecting with communities using very different literature and very different recruitment methods in order to secure as many local people into employment as we possibly can. And you'll see on the next slide, it just gives you some lovely pictures on some of those days and some of the things that we've seen. But we're also trying to think about people that are in education. So the next slide on 241 shows some of the work that we've been doing with some of the colleges, in this case Coulsdon, where we have looked at the range of people that are taking qualifications in health and health-related topics. And we have engaged them to think about a brief, think about what they've learned, and try and find solutions with us to some of the issues that those briefs themselves then align to. And in this case, 140 students participated. Each student considered a challenge, and they presented back to South West London leaders and managers and were awarded a certificate of achievement that they can then add to their CV, but also just tries to connect the programs that they're learning into a kind of a real life situation so that they can take that forward as well. We are obviously continuing to do that. So in the next slide, 242, in primary care, we're working with South West London training hubs. 3-week courses are being developed, a week in the classroom, and then 2-week project-based work experience across primary care to encourage people to think about primary care as a career. And then in relation to our kind of online presence, we're also trying to make sure that there's a one-stop shop, there's a single point to go to if actually you're thinking of a career in the NHS in South West London, that will obviously link to everyone else's websites as well, but a simple way of trying to get information to people on the kind and range of careers that may well be available to them. But a really important priority for us is to care for the people that care for others. And you'll see on slide 244 a range of health and wellbeing initiatives that are supporting staff through issues with mental health, to support women's health through the Women's Health Project, and also with men. And you can just see the kind of numbers of people that are coming through there. So in relation to the mental health hub, if you go back to the sickness, one of the third reason for sickness was mental health, particularly trying to take a very different approach to mental health, offering enhanced support. 1,421 people current receiving support through that hub. So trying to really take sickness issues, trying to take the health and wellbeing priorities, and then make sure that they address those needs. In relation to some of the things that we're doing in retention on 245, we are working with Capital Nurse on a flexible working programme. So there's a pilot that is currently underway, 5 expressions of interest from ward managers across inpatient settings, looking at how do you as a manager and a ward manager begin to support staff more creatively in terms of flexibility, because when we look at one of the reasons for leaving, lack of flexible working options is one of those reasons that people leave us. And then we also know, don't we, the cost of living challenges that everyone faces at the moment, and trying to look to make sure that we talk to people about what their priorities are, and then talk to organisations about how to then address those challenges that people face. What I would say about a number of these areas, and it's in the key risks, is these are funded short term. So we will have to think about how do we fund them in a longer term as we move forward, both from a system perspective but also from local organisations' perspective. If we go to 247, it's really important that we have workforce data. If we haven't got the right data and information, actually the initiatives won't make the significant impact that they could. And we've challenged, so as a system, we don't have access to the workforce information that either Trust do or the national team do. And I've raised this with London and I've raised it with the national team. In the absence of that, we are looking to develop our own information and pull together our own information so that actually we can make more long-term decisions around workforce priorities and transformation programs as we go. We've explored the federated data platform to see whether actually that as a kind of a national initiative would encourage the use of workforce data, but that's not part of it. So we will continue to scope what we need. And as part of the new ICB workforce team, we have a business intelligence lead that will help us then begin to bring that information together. Helen's already talked about the financial challenge, and on 248, there are 5 programmes that are led by Chief People Officers across the organisations to begin to make a difference from a system perspective. And we've already talked about bank and agency and the need to get those numbers reduced so that we can actually meet the workforce challenge reduction that Jonathan outlined in the operating plan. But there's more. So how do we come together on shared services, work on apprenticeships and making sure that we really use apprenticeships well, but also how are we rostering staff and how could we do that differently. And what we tried to do through the 249 on the ICP Priorities Fund, we successfully awarded the Apprenticeship Hub. And that is taking a very different approach to apprenticeships. So making sure that we are marketing things differently, that we're really identifying the specific roles that we want to target where apprenticeship could make a difference. So healthcare support workers, pharmacy technicians, administration, leadership management and coaching are the areas where the group at the moment have agreed that they are the priority areas. So looking at developing career pathways, looking at making sure that people know that apprenticeships are available in those areas, but also where we are underspending on our levy, trying to work and share that levy with the community and voluntary sector so that actually we can make sure that our wider partners also benefit from apprenticeships. And then 2 final things. On 2.4, I think it's 9, but my number's disappeared now. NHS Care Leavers Covenant. So the youth employment, you'll see at the top there is a quote that says, "A large proportion of young people leave the care setting poorly prepared for independence." And there is a government initiative that is looking to support care leavers who are aged between 16 and 25 to support them as they move out of care and to be able to live more independently. And we are launching webinars to increase awareness about that with managers. We are looking to make sure that we support care leavers as much as we possibly can. And we also have it as one of the, I think, Sarah, it was in your presentation around the work that's happening with Roehampton Institute on an introduction to nursing course for people specifically coming from the care setting to support them. So some work that we are leading with care leavers as well. And then the final one is the importance of middle managers. And we're working with Chief People Officers at the moment to develop a middle managers development programme to make sure that we are supporting them in the really difficult role that they do, but actually that they have heightened awareness and skills in relation to inclusive leadership practices. And we were looking to start that course in September. So huge amount going on, conscious of time. So just to say that actually none of us alone can solve our workforce challenges. We've had that conversation around this table many times. It's going to take a huge amount of effort from all of our organisations to make sure that we continue to address those. And those projects that are aiming to support us to attract, retain, develop and transform our workforce differently are things that we will continue to bring back and share with the board. But I just ask you to note the progress. Thank you.
Thank you, Karen. Great to see so much work in this space. Can I ask if there's any, if I go to Jacqueline first.
Thank you, Karen. I think for most chief execs, their staff is a lot of where their heart is, because actually they're the people giving care to your population. I think you said that, but it's absolutely true. I just want to talk a bit about the bit about flexible working, because if you run a ruler over most of our staff surveys, as you said, flexible working tends to be the biggest underlying issue for staff. And I think there's a bit between what each type of staff group actually mean by that. For nurses who work on a ward, it means fair and transparent and well-managed rotas, because they can't go home and work, so that's what it is. Junior doctors are much the same, and it's the biggest bugbear if you ever look at Twitter, actually, for junior doctors. But we all have policies about flexible working that actually, I know mine's the same, says it's all down to your local manager. And then we get really inconsistent policies. So there is something about how do we develop flexible working policies that actually means we try and standardise some of that decision making and don't give it all to local managers who are then accused of being unfair when actually they're trying to run a service. But sometimes they go a bit too hard and sometimes they go a bit too that way. We mismatch that. So I think that would be a helpful thing about how we do that and how we delineate between truly flexible, where I can work at home one day a week, to what we mean by well-run rosters that are fair and transparent working practices.
Yeah, I think that's a really good point. I know with my other hat on, we've launched something in our midwifery, and amazingly, we've got some midwives who actually only want to work between 1 and 4 in the morning. Just amazing, absolutely amazing.
Self-fostering is a big thing.
Yeah. So it's the opportunities are amazing. Elisa.
Hi. Thanks so much, Karen, for your presentation. I have a two-part question, if I may. The first is around the new NHS doctor apprenticeship scheme that's being launched nationally. So this is a scheme where medical students can work in an apprenticeship style, developing their clinical skills, and it aims to attract underrepresented groups, because this enables people to get paid essentially while they study. Do you know if we're going to be accepting a cohort of students in Southwest London, is my first question. And my second question is around the evaluation that was being led by Flare Impact that we heard about at the ICP meeting, and that was around, I think, measuring NHS staff's perceptions of racism in the workplace. And I was just wondering if there's been any progress made on that. Thank you.
Do you want to come back in on that?
So just I'll come back to Jacqueline as well. So I think that's the importance of conversations with people about what does flexible working really mean. I will ask Catherine to make sure that we're building that in terms of the kind of the consistency across, that we'll build it into the retention stream within South West London. Alicia, the doctor's apprenticeship is still quite new, it's developing, and actually we were in touch with the national team about it recently. It's not likely to be ready until January of next year anyway, so I think we'll have to explore it as we go along with the trusts and think about how do we bring that in. In relation to Flare, we have had expressions of interest now from organisations that want to take part in the Flare process. We haven't had the outcomes of that yet. As soon as we do, then we'll share it both with the partnership and with the board.
Thank you. If I can go to Vanessa, then Elaine, then James.
So I was just going to say the support that we received to run that recruitment day was really excellent, and to do it jointly I think is a much more effective way of doing it. So it would be great to have other partners to join the next one of those, so perhaps some of our acute colleagues, primary care, etc., because there's huge talent out there, but I think that there's then a challenge that we're also recruiting people who've got degrees, qualifications from other areas, that we need to use those skills properly in our NHS, and I think that the benefit of doing that across providers and with the third and voluntary sector, actually, we should do it together. So,
Elaine.
Thank you. I was just going to add, in terms of the flexible working for nursing, there's 2 big trusts in London that have done some really good work on what they call team rostering. And myself and some of our CNOs in South West London met with those trusts and seen some of the data coming out of those pilot projects, which is really positive in terms of retention, staff satisfaction, reduction in sickness, reduction in bank and agency, all the key metrics that tick lots of our boxes and all the right things for us. And there's quite a lot of interest with some of our CNOs in South West London to pilot some of those projects as we go forward into this year, part of some of our wider work, which is really exciting, I think.
It would be useful to have that come back to the board, Elaine, at an appropriate point. James.
So this report really builds on a number of areas that, as Jacqueline said, we see coming through the staff survey. We see in our conversations about what it feels like to work in our organisations, and we're relatively unique in the NHS for having a really huge middle management workforce, and generally you get to be a middle manager by being good in your area of practice, whether it's a clinical or non-clinical practice, and then you get promoted, and then suddenly you have this sometimes quite significant staff management responsibility, but the support mechanisms around that differ massively by professional group and training route, and a lot of what we then see come through in terms of staff experience is really driven by the innate ability of those managers to respond to that challenge rather than how well we equip them. So I was really pleased to see the bit about inclusive leaders and middle managers, because even if we do get all of our policies right, there's still an awful lot of room for interpretation, and how we support those midwives who want to work for 3 hours in the middle of the night to access the statutory and mandatory training and be well and successful in that working pattern does rely a lot on middle management skill. So I suppose my question, I absolutely endorse the approach. My question would be, we've got the 40 places, we've got the engagement, but it's the scalability, because we know that for this to be a really successful intervention, we need to get out and significantly upskill in a really scalable way a really, really big middle management workforce.
And when we look at our staff survey and look about who are our unhappiest staff, they're our Band 2 admin and clerical. They're usually managed by someone who's now a Band 4 admin and clerical. It used to be a Band 2 admin and clerical. And we just, when we talk about middle managers, we forget that those lower band ones are the ones that actually have the biggest impact on people's work-life balance or working practices. And we forget about that. And we recognise that ourselves when we look at that. So I think for me, we need to make sure we get to that level as well, because it's where, and I think the other bit, and we've started to recognise this in our own practice because we've got loads of management courses, is there's a lot of good stuff in there about, you know, about looking after staff health and well-being, all about values. What we don't really tell them is how to have a really tricky conversation with a member of staff, because those are the ones that usually go really wrong, and those are the ones that actually usually end up where you end up with I'm raising a concern or a grievance. So those are some of the toolkits, I think, that we could develop that help all levels of staff that have never had to. I learnt it by trial and error, which I suppose was often how we often did that. But actually there is, why shouldn't we get in early and actually give people good practices for having tricky conversations?
Jeremy.
Yeah, so I really welcome the approach set out in the report, particularly about the new approaches to recruitment. You know, you talked about the job fairs and more flexible approaches, and particularly the ICANN initiative. I went to Roehampton last week, and I thought that was very positive. Saw some young people from that initiative. One question. In the demographic data, there isn't anything on the age profile of the workforce, and I just wondered to what, I'm assuming that's a big factor in our challenges. And then the second question is just on, I'm leading some work on the social care workforce within our area. So it's just about, there may be some areas of crossover. So for example, I'm looking at if there are opportunities for social care workers to progress to be healthcare assistants, which helps them with their pay and their career progression. Some way of us looking at different hybrid roles, something. So I'd be keen to work with you on that. Thank you.
Come in on that. Yeah.
Okay. Should we start with management development? So James, we've got that particular programme of those 40 is through one of the higher education institutes, so actually it probably is scalable. We were talking with CPOs probably about 4 weeks ago about, do we all need to train in the way that we do? Because actually, could we not develop a standardised model for management development that actually would go across all of our organisations? If you think about how we could better target our resource, the resource that we could probably save with that, and the consistency, particularly if staff then are moving across our NHS organisations in South West London, the culture that they then bring could be similar. That would take quite a different approach from every organisation to be able to buy into that. But for me, I think if you looked at all those programmes, we're probably training the same things maybe a little bit differently. Jacqueline, your point about courageous conversation. The organisation I was in before, we had a real problem with that. And we had a very big focus, and we brought somebody in to have courageous conversations and trained everybody on courageous conversations. Not only managers, but also staff to be able to raise it. So that's why I think actually if we design something system-wide on management development across the ranges, I think we could make a much bigger probably impact on some of the changes that we need to make. But we'll talk separately to you all about that. But we are beginning to have those conversations with CPOs. Vanessa, your point about people coming into the organisation with lots and lots of different experience and lots of different skills. We did Ruth and I were at the People Board recently, and we saw a report that we had commissioned on social mobility and what people wanted, but also what they had. We've shared that data with CPOs, so we've got a whole insight into the people that certainly filled the survey in about what they're looking for and what they bring that we're currently not maybe helping them to fulfil as much as we possibly could. So that information is with CPOs. Some of our issue is around our data. So as I said, we've got to develop that data set, but certainly we do know that we have an ageing population, particularly in primary care. So if you look across primary care, then actually we've got significant numbers in primary care over the age of 55, and therefore what are they thinking about in terms of their futures? And then just in relation to social care, hybrid roles, etc., we're working with the Integrated Care Partnership on workforce as well. So those conversations, I'm more than happy to tie in with you and share some of that work that we're doing there. Was that everything?
Jeremy, on
Was
that
those?
final point, Central London Community Healthcare, which provides community services in Merton and Wandsworth, have been doing some pilot work on just that issue in North West London. So they may have some, I'm not quite sure where it's got to, but they were doing some pilot work.
Should
on
be able to do that, though.
pathways.
Yeah, definitely.
Annette and then John.
Thank you. Thank you, Chair. So, Karen, I wanted to just come back on your what you were talking about, standardised management programme, and ask whether we would be able to extend something like that to primary care as well. I think it would help primary care enormously. Absolutely. It would help career progression within primary care. But I think on top of that, it would help the system as a whole, I think, as well. So I think that would be enormously helpful. And then, Jeremy, if you looking for HCA development, two of the most difficult posts to recruit to in primary care at the moment are practice nurses and HCAs. Really difficult. Not only do we have an ageing population there, but we also just can't, it's really difficult to attract. So if you do have staff who are looking to develop HCA skills, please come and talk to us in primary care, because we can probably help, and we would benefit as well. So great, thank you.
John and then Zara.
So, Karen, really helpful paper. Good to see all of the positive stuff that we're doing. I think it's just worth looking at the size of our primary care workforce, which is staggeringly small when we consider the amount of work that they actually do. So for every acute bed we operate, and this is rather simplistic, we probably have 12 to 13 staff supporting in the acute sector. So I suppose it places the emphasis and the importance around getting our prevention right, getting our long-term conditions right, because that's probably the only way we're going to get that workforce shift back into primary and community care. Because we've got 30,000 colleagues working extremely hard in the acute setting, but with the exception of maternity, which is not an illness, it's a healthy state, everything else is focused around a disease model. So in terms of our ambition of shifting the cost of care, we have to look at it through that particular lens, I think.
Zara.
Just wanted to add that, as you can imagine, the voluntary sector also has very similar challenges, particularly around recruitment and retention. So one of the pieces of work I'm really interested in is around training and development, and kind of looking at what you've got here and the programs you're describing. I can see, interest within the voluntary sector to tap into those, but also, I think there is an opportunity for NHS colleagues to tap into the training that the voluntary sector provides. So I've been doing, as part of the Alliance work, we have been doing little pieces of work, but I think the training provision within the NHS is so fragmented and complex that I'm not quite able to get to all different training providers and do a piece of work that is a bit more consistent. So yes, I would appreciate any conversation around how do we do that? How do we capitalise on each other's development programmes and training and kind of do it cross-sector a bit more? Yeah.
Helpful, yeah. Karen, did you want to... I can't see any more contributions. No. Did you want to say any final words?
Thank you very much for your interest. I think... so. I'll probably finish with what I said at the beginning, which is, I suppose we have many collective leadership challenges around this table, don't we? Workforce is going to be one of our most significant. And it's really good that we have such good partnerships at lots and lots of different levels that are working on this together, because not one of us can solve this on our own. So I think as long as we continue to work together on it, that would be my plea.
Thank you, Karen. Sarah?
So I just think this is so important to us across the NHS and local authorities as well, and our partners, because I think 80% of our resources is spent on our staff. We are a service industry, that we talk about often how do we engage with patients. Our staff, nearly all of our staff are engaging with patients on a daily basis. That's what they do, and actually we need to support them. And you talked about caring for those that care for others. That is such an important comment, I think, around how we work in the NHS, and it's so important to us that we support those staff in a different way, and we actually attract people, because as we all know, working in the caring profession is actually hugely rewarding for us as individuals, and actually the more that we can encourage other people to become involved in what we do, I think the better really for them and for us. So just a really positive piece of work. I think the more we can do together to make this right for our staff and for our local people, the better.
Fantastic, thank you. We'll move on to item 11 on the agenda now, and I'm going to ask Sarah to give an update on the Integrated Care Partnership Board.
So this is going to be really brief because we haven't actually met since the last time we had a governing body, so there is no update from the board, from the partnership board. However, as we mentioned at the last board, Councillor Ruth Dombey has retired now, and we are awaiting confirmation of the new co-chair, the ICP co-chair. So hopefully in the next few weeks we will be able to confirm that. And also we are going to be cancelling, and I think we've already let people know, the July board, because it's the middle of the summer and we've just had an election and people are very busy and we've had a lot of apologies. So we've decided actually to hold over now till our October meeting. So in this paper, this sets out some of the things that we will be discussing, which we will be discussing in the public board in October. But work is ongoing outside of that board, and we are working together across the partnership to deliver on our strategic aims.
Fantastic, thank you. Any questions on the ICP? In which case I'll move straight on to board committee updates and reports. There's a written report on the Finance and Planning Committee, so Helen, over to you for the Finance report.
Thank you. So at the Finance Committee, there has been one meeting since the last meeting where we covered, as you would imagine, the operating plans, the performance in 23-24 and the infrastructure strategy. And over and above that, we looked at some of the transformational and partnership and collaboration work that had been ongoing within the places. So just to provide an update on that. If we look to the finance report, which is the month 2 finance report, this shows that we are in line with plan at month 2. However, we are £2.3 million adverse to plan on our efficiency delivery, and we've also had a switch between recurrent efficiencies to non-recurrent efficiencies, which obviously provides a risk to us as we go forward, recognising that our savings requirement starts to kick up in month 4 delivery. It's also key to note that we are below the agency cap for the first time. We've seen a significant amount of work done by all partners on workforce controls and workforce, and we have significantly reduced the agency that we have. However, the cost per whole time, particularly around agency, is higher than that what was planned. So we're doing a lot of work around that in the background, around the fact that we're using the different sort of case mix, if you like, of agency than we were expecting to use at the beginning of the year, and why is that, and what's driving that, and what work can we do to support that. And just to highlight the key risks within the delivery of the plan is obviously the savings programme and the delivery of the planned activity within that as we go forwards, but also industrial action. We have now seen industrial action at the end of June and the beginning of July, and we were required not to plan for industrial action when we were putting the plans together. That was part of the operating guidance, and so that is excluded from it at the moment. So we will have to look at what that looks like as we go forwards.
Thank you for that. Any questions for Helen on the finance? In which case we'll move on to quality and performance. Mercy.
Yes, just very briefly, the Quality and Performance Oversight Committee met on the 12th of June. I'll let Elaine and Jonathan talk about the quality and performance data that we looked at. Just to say, we also looked at the NHS England tiering and system oversight framework, and South West London were okay in that, so we weren't in the kind of needing intervention group, so that seemed okay from the NHS England point of view. And also we did a deep dive on the infection prevention and control kind of area, which was really interesting, and looking at the challenges and mitigations that we were doing in those areas. So that was really welcomed by the committee, but I'll let Elaine and Jonathan talk a bit more about the quality and performance data.
So if we go to Elaine first.
Thank you. We also talked at the committee about the PSERF framework and policy and the progress that's been made across South West London. Now all trusts have transitioned to the new PSERF. So we've got a PSERF framework and policy that's now been agreed and published across South West London, and we continue to work well across system partners with that. We talked a lot about, and I'm sure Jonathan will talk about, emergency department, urgent emergency care performance, but we talked about the quality impacts of that, and in particular long waits in emergency department and mental health patients in that pathway. We have established our place quality groups now across all 6 boroughs in line with the new structures, and some are more established than others, but I think we're starting to see some consistency, and the committee is starting to see some reports from those place committees. So more work to do, but I think some significant progress is being made. We talked a lot about continuing healthcare and the quality impacts of continuing healthcare and the KPIs, and an update in terms of how we're doing with our transformation progress. And the continuing healthcare teams have now transitioned into the new place teams as part of the management restructure as well. We noted and discussed our risks, and in particular we talked about a new potential quality risk around long waits for children's therapies, and we've got some more work and some more reports coming back to committee. As Mercy's alluded to, we spent a lot of time talking about infection prevention control, and I think it's fair to say that most trusts across the country, not just in South West London, have seen an increase in hospital-acquired infections as we move post-pandemic. And there's a significant amount of work doing and learning across South West London and London in terms of those infection rates, the learning and improvements and action plans, and we'll continue to monitor that. I think that's probably a summary of the quality report and the main issues that we discussed, but I'm happy to take any questions.
Any questions for Elaine? Thank you, Elaine. Jonathan.
Thank you. As you might expect, Chair, there's a lot of alignment with what Elaine has had to say in terms of some of the key areas. So just to pick out the areas of success and the challenges that are described in the main paper. So just to note on performance against the 4-hour standard, as is flagged here, we did well at the end of last financial year, and actually collectively as a system we're continuing to do well on that indicator. Most of our trusts are beyond their expected trajectory at this point in time, so that's a good measure, though I will come back a little later to talk about long waits in the emergency department. I'd also want to say our 111 provider has moved from being certainly, I think, one of the more challenging in London to one of the more successful, and that's really clear from looking at their key performance metrics. Mark and Sarah talked about this earlier, about learning disability annual health checks and the work that's gone on there, some really stellar work involving primary care to exceed the target by 10%, real achievement for our learning disability community. And on cancer, we continue to hold our head in a good place in terms of our performance on cancer delivery. And also, just to give a slightly more longitudinal perspective, really good to see some of the work that Royal Marsden Partners have been doing around staging completeness and seeing our progress that we're making in diagnosing cancer earlier. I mean, that's a key metric for us. We lag behind most of mainland Europe in a number of areas, and we're really starting to see some progress on that. If you look back, say, to 2018 against now, you can see progress. So that's really good to see. And then in the areas of challenge, we have a target to eliminate all over 65 waiters by the end of September. That is going to be tough given where we are at this point in time. Trusts have had issues with theatres at capacity and availability, amongst other issues, so that's something we're monitoring almost on a daily basis at this point in time, but that's going to be an ongoing area of focus through the summer. And then, as Elaine has called out, our challenges, which I've mentioned here many times before, on long waits for people in emergency departments, both for physical and mental health, is attracting, quite rightly, scrutiny, and is frankly why I'm so passionate about trying to deliver the length of stay reductions we set ourselves, because that feels like a route to help with that challenge we face at the moment. And then the other area would be, we've seen a little bit of a drop in virtual ward utilisation from what we saw in the middle of winter. So we working with the director lead on that to try and secure some consistency of service model across South West London, so that we make the most of that capacity and that precious resource that we have. So hopefully get that a sort of balanced assessment of some of the strengths and weaknesses.
Really helpful, Jonathan. I mean, on the virtual wards piece, because we are have historically been the best in the country in that space with the number of beds and the utilisation rate and the acuity of patients. Is there anything that's driven the drop in performance that we're aware of?
I think in the it may be my assessment, it's more anecdote than anything else, but I think in the depths of winter there is such pressure on the system then that people are probably part of the issue always in this space is trust, to use that word that was used right at the beginning of this session, between primary and secondary clinicians, and confidence about what's happening in the community. So I think perhaps that's an area we need some ongoing work. I think there are also different service models aligned to the degree of community integration that we have in different boroughs and different parts of the system. That is certainly something I wanted to explore with Lucy Waters as the lead director. So others might want to give a more factual account. That's somewhat anecdotal, but those are some of the feelings I'm hearing through the UEC board and elsewhere.
We may want to come back to virtual wards as a discussion item, particularly if we have more chief execs present from the trust, because they will have different perspectives. But James, if I could bring you in.
This isn't totally sort of quantified either, but I do spend quite a lot of time with my teams and in the hospital and also with place teams. talking about this issue. Before this meeting, I was with the Sutton Alliance, and we've done a lot of work around the PCN multidisciplinary teams and the frailty cohort. And we were hearing some of the initial data, and what was being fed back was actually about the psychosocial complexity of many of the patients that the PCN MDTs were needing to look after, and that many of the interventions they were needing to organise for the PCN MDT cohort were actually not healthcare interventions, they were social care or wider interventions. And I think that very much speaks to the challenge that we see in terms of psychosocial complexity with the discharge cohort as well. So when you have, I think, a group of service users whose needs are for physiological monitoring and perhaps a little bit of personal support, it's relatively straightforward to get them down a virtual ward pathway. I think when you have significant wider complexity, what you're then needing is possibly the virtual ward plus other forms of support in parallel, and that then becomes much more difficult to organise, because then actually potentially a physical setting of care may be able to do more of those things sort of in a more kind of wrapped up way. And then also you've got, say, changing junior doctors, turnover of staff. As Jonathan says, people have to be confident in the mechanism that they're sending a patient through. So I think that psychosocial complexity that we're seeing in many different settings of care makes it difficult to sustain a virtual ward model, because there is that trust, there is that slight sense of the unknown, and are you going to be able to support all of those more holistic needs that an individual have? I think one of the challenges we have as a system is really quantifying that increasing complexity, because we all see it and feel it, but actually putting it into numbers is really difficult. So that's my sense from working with teams in both place and acute in terms of what's coming through, and I think that makes sustaining utilisation of a virtual ward more difficult. I don't think it means it's the wrong thing to do, but I think it's finding ways of supporting people in that context is our challenge.
We'll think about it. It may merit a seminar discussion, actually. It feels like there's enough meat in there to talk about Vanessa.
So slightly building on what James was saying around the added complexity. So the more options you add in around virtual wards, you add in greater complexity, don't you, into your acute area. And I fully support, Jonathan, the kind of the correlation between some of our breaches at the moment and length of stay. And we've been working under sustained pressure. So linking to Karen's report on workforce, our workforce has been working under sustained pressure, increased complexity and acuity for a long period of time. And within that, the importance of multidisciplinary team working and clinical risk threshold is really critical, isn't it, to solve our length of stay issue. And that becomes really difficult with some of the way in which our staff get openly criticised. And the coroner's processes. I'm not saying that the outcomes isn't wrong, but all of that adds up to a really difficult set of dilemmas that our staff face every day. And I wonder what we do then as a board to help and support some of the clinical risk decision making that we're asking our staff to make, because we can do it as an individual organisation, but I don't think that's really the answer anymore. I think we've got to look at it much more from a system perspective. I'd love to see us have a fuller conversation, maybe at a board seminar about it, but then perhaps bring something back, because I think it would mean a lot to our staff to have that conversation in public.
Really good idea. We'll take that away and work it through in terms of how we can take this forward. Thank you for the reports. We'll move on to the Audit and Risk Committee.
Thank you. So the Audit and Risk Committee met on the 11th of June. We received the annual report from our external auditors, Grant Thornton. That was a clean set of accounts they reported on, so we were pleased to see that. We also reviewed and commented on the annual report and accounts, and we were happy to recommend that forwards. We received as well the annual report from our internal auditors, summarising the work they'd done for us through the course of the year, and their overall opinion for the year, and they're now into their internal audit plan for this year as well. We we looked at the board assurance framework and the strategic risk register, went through the strategic risk register, made some comments there. We also recommended that it would be good for the board to have a workshop or a focus on strategic risk, and particularly to have a conversation about risk appetite and risk tolerance that can then be overlaid onto the board assurance framework as we go forward. And as you know, we reviewed the scheme of delegation, standing financial instructions and standing orders. Thank you.
Thank you for that, Martin. And certainly we will also look at the way in which we could look at the risk appetite. Thank you for that recommendation. Moving on to the Remuneration Committee, Ruth.
Thank you. So we reviewed the terms of reference, which we've discussed at this board. We had a further update on the management cost reduction programme, which included both an update on the discussions with NHS England in terms of the business case, and secondly on the continued work that's happening around reducing the number of people at risk of redundancy. We had a discussion about the policy position in relation to partial retirement, which is a relatively new approach that has been taken, and what that meant in terms of the redundancy programme. And then finally, we had an update on the implementation of the clinical leadership model work. Thank you.
Thank you. Any questions for Ruth? In which case we will move on. We'll note those reports and we'll move on to Chief Executive's report. Sarah.
So, short report. I just had two sort of really big thank yous actually. One is, as was mentioned earlier, we still have ongoing industrial action, and I did have some industrial action at the end of June and beginning of July, and that was managed by our providers, and that's a big thank you to everyone. We do hope that some of the discussions that are ongoing now will lead to a resolution of the junior doctors' strikes in the future. Let's all hope for that. The second thank you is specifically for St George's, because it does mention in here the cyber attack on the pathology services in South East London. Obviously had a massive impact in South East London, but St George's did supply a huge amount of mutual aid to South East London at that time, and I know that we would all like to thank St George's and the team over there for the work that they did. There is still an impact, I think, from this on both us and South East London now, but really important that we as an NHS work together at times when we have these difficult things happen. I wasn't going to say anything more about anything else on the report, but happy to answer questions. But I did want to add something, just because I did get a report through very recently, which Nicola might want to mention it, which is the GP survey for South West London. So absolutely recognising that general practice is under a lot of stress and is really busy, but and there will be things I am sure that we can improve in general practice. But when you look at our GP survey results for South West London, we have some of the best results in the country, definitely the best in London, and some of the best in the country. And I think that says a lot about the positive impact of the work that primary care are doing in South West London. So congratulations to primary care. I do know there are still things in there I'm sure that we can get better, and I'm sure that our local people, there are some areas where they would like to see improvements, but I do think that's a good reflection on South West London primary care that we have such a positive GP survey. I didn't know if you wanted to say anything on that, Nicola.
No, thank you for mentioning it, Sarah, because I think there are practices working really, really hard out there, and I think they deserve to see this. But it is on a, I don't want to put a huge downer on it, but we have to take it in the context of actually it feels very hard. There's a lot of demand, and patients might not be always sensing that this is the case. I think the results across the country are not completely comparable to previous years because the questions are different, but nevertheless shows that there are challenges everywhere. But it's a great place for us to be now, given how the world of primary care is, and I think we just need to be ambitious for our primary care locally.
Thank you for that. Thank you, Nicola. I've not been notified of any other business. Is there any other business that people would like to raise? In which case, we'll move on to public questions. I've had one written question from Roger King, but Roger, I understand you're here. Would you like to read out your question rather than me?
The question is several parts. Can I just explain that I'm the chair of the Croydon drop-in, and that's the reason why I'm here, and that's the reason why I'm asking this question, because we've got some financial difficulties associated with the invoices. What I said in the question was, for the period ending June 2024, what is the total outstanding unpaid invoices for the sum of contracted work? It's linked with the section 6.1 of the finance discussion that you had earlier, which actually says your standing financial regulations, version 2, section 6.1 states payments for goods and services is made in accordance with ... prompt payment practice. So I was asking the question about unpaid invoices because that's been our experience at Croydon drop-in. I also went on to say how many complaints have been received regarding non-payment of contracted work invoices. What is the impact of the non-payment of contracted work invoices having on contracted service organisations, hence drop-in, but I know others have got similar issues and problems.
Thank you for that, Roger. Helen, this one's for you.
Yes, thank you. Sorry, so apologies that if you've had an issue with payment, that's not where we want to be or where we want to be. We recognise it's really important for organisations to be able to have the appropriate cash flow to be able to support themselves as they go through. As you quite rightly said, there is a standard about prompt payment within the NHS guidelines that we have to follow, and that is that we are required to pay at least 95% of our invoices within 28 working days. Of them being appropriately received. I can confirm to you that we received 71,000 invoices for non-NHS suppliers and services last year, and we paid 99% of those within the 28 days. And in June, when you asked about June 24, just to give you a feel for what was in the last month, we paid 6,618 invoices. Again, 99% of those were within the standard that we were required to meet. Now, obviously, we want to aspire to get to the 100%, and we want to learn from anybody's experience that hasn't been good so that we continue to improve what we do. So I'd welcome a conversation with you. Just to come back to the question about complaints, we haven't had any formal complaints around that, but when we do get inquiries, we try to respond on those as quickly as possible to solve the issues of where they are. But I do recognise it is really important to support organisations so that enable their cash flow.
Can I respond, Mr. Chairman? I raised the issue in a letter on the 26th of June.
I raised the issue in a letter to you on behalf of Off the Record and Croydon Drop-In on the 26th of June, to which I received no response. Later, what I did was to phone up, and eventually I got through to your complaints department, a very helpful person called Lee, who said that she would send out my email to a whole range of other people. Eventually I got a response back from Neil McDowell on Friday of last week, very apologetic, said that the issues shouldn't have happened, there was some delay. We haven't been paid for 6 months, 166,000. As a small charity, what we can't do is to continue to take money out of reserves in order to pay ongoing salaries. So what we've got is an issue now that has been resolved, I think, for the last financial year, which means up to the end of March, we've got that money in, but the period between April and now hasn't been paid. We've got an issue about putting invoices into the system now, and we're going to be another 6 months, presumably, before we actually get paid for the work that's currently going on, for which we're commissioned. We've got a new piece of commissioned work that should be coming in September. Recruiting staff, wave 6 of the MHST monies. what do we do as a small charity? Do we say, no, sorry, we can't do this. We can't continue to employ staff and not get the money to pay the salaries? Or do we go to the staff and say, very sorry, but we're not going to be able to pay you this month? It is really getting that dire. And what I need from you is some assurance that we can resolve the problem and we can get regular payments coming through so that we can continue to pay the salary bills.
Roger, thank you for raising it. Apologies again. I'll repeat Helen's apologies. I think Helen has offered to have a conversation with you outside of the room, and I will ask Helen to update me on that conversation subsequent to it as well. All of the points you've made are absolutely valid, and we need to make sure it's not happening. Charlotte, would you like to come in on that?
Yes, obviously to echo Helen's apologies, but also just to a bit of light at the end of the tunnel. So I think we are working with SARA and the Alliance to support smaller organisations around how to navigate NHS bureaucracy and actually get your bills paid. So we recognise it's an issue, and also that the NHS system is complex and difficult. So we're going to work with SARA, with the leadership team and the Voluntary Sector Alliance, with finance, and actually produce a communications toolkit, you know, with kind of videos, screenshots about how to navigate that bureaucracy. And then we're also going to put in place an escalation process, because I think it is difficult to kind of get into the organisation. So I'm going to ask my engagement leads at place to be the contact for people who are having difficulties with finances, to kind of be the go-between and navigate some of the bureaucracy behind the scenes to support you and organisations like you to try and, you know, smooth that process going forward. So I'm sorry, and I know it's difficult now, and we can, you know, with Helen try and fix it, but going forward, hopefully we can make things clearer and easier so we're not here again.
Can I add to it very quickly? We've been talking about trust, you know, and kind of building trust, and voluntary sector organisations seeing themselves as equal partners. I mean, we had quite a few cases of organisations actually coming to us with similar problems of unpaid invoices. And I think thinking that organisations feel they can be seen as equal if they don't get paid for 8 months is a bit delusional. We really need to find a system to make sure that, you know, these invoices are paid on time, and whatever arrangements there are between recommissioning or commissioning someone else, you know, the kind of, if you want, period of pause in between choosing a new provider and continuing the service are kind of done properly and seamlessly, because you know, I've seen quite a few groups really on the verge of falling down because they were not being paid, and I don't think this is acceptable. I really think we need to find a way internally to make sure that it doesn't happen, because what we see as a probably just a logistical, you know, issue, internal issue, is really impactful in a detrimental way for a small charity. And these are medium-sized charities which have some reserves. So the smallest charities wouldn't touch the NHS, you know, because, you know, the payment issue is out there, and they know it. So.
Thank you for that, Sarah. And Charlotte, look forward to hearing how the work progresses there. I'll now take other questions from members of the audience. Wendy.
As I've mentioned before, my name's Wendy Micklewright. I hallucinate, I hear voices, I'm not ill, I don't take psychiatric drugs. Using the Freedom of Information Act, I'm glad that some people mentioned social determinants of health. Last time I was here, I mentioned housing first policies, which I haven't heard anything about that. And I think we need to consider those things. And we also need to consider some of the assumptions that are based within the mental health system. So there's James Davis's books, Cracked, Why Psychiatry is Doing More Harm Than Good, and Sedated, How Modern Capitalism Created the Mental Health Crisis. So I was also involved the UN. It was two charities. It was Runnymede Trust and Amnesty International, who were doing a piece for the UN about racism. And we commented around racism within the mental health system. We've once again done our freedom of information requests, trying to highlight these issues. Of the 50 trusts that we've contacted, 21 of them have responded so far. There's still approximately 1,000 people a year receiving electroconvulsive treatment in this country. We did get the data, thank you very much, from South West London St George's, and that is quite disturbing. It's disturbing. Most people don't consent to ECT. I think it was 24 women and 12 men. So to me, that smacks of sexism. And I'm not alone in that assumption. I think, I think John Reid has raised this issue numerous times. So we think there's about roughly 100,000 restraints happening in the mental health system in the UK, about 5,000 seclusions, and then there's the issue of medication. There's also some information on the Mad in America website, a former policeman saying how untherapeutic mental health systems are and hospitals are. There's a former doctor who, again on the Mad in America website, saying how doctors are trained in a certain way and they're not particularly good generally at critical thinking because they're trained to pass exams and then there's another person there, Jessica Schreidler, and she's talking about she has a problem with anorexia, and she's been doing some work as a psychologist about single session interventions. So I would suggest you look at that. The thing I really wanted to talk about, though, is a friend of mine who sadly died. I first knew him when I knew him through his mum. He was in the mental health system from the age of 15. I used to visit him every month if he wished me to. I think I went to about 5 or 6 different institutions to see him. I attended online meetings for his tribunals, something that I talked about last time I was here. His mum was, if she didn't agree to him being Section 3 under the Mental Health Act, she would have been removed of his nearest relative. Last time I visited him, he was in a hostel in North London. When I was sitting in on his tribunal, it was very heart-rending because it was very clear that he was heavily sedated. He was drooling, and I don't know if you're aware, but mental health drugs will cause sexual dysfunction in men, and that's commonly known. So these are all the issues that he was contending with. So from the age of 15, he was in the mental health system, and he died at the age of 32. And this is the people behind the statistics. This is the people behind asking under the Freedom of Information Act what's happened to people in the last year, in the last month after being restrained. And I just don't understand why we haven't moved forward, particularly with electroconvulsive treatment. I don't know why we're not listening to other countries. I don't know why we're not taking best practice from other countries. I don't know why we're not listening to the UN and the World Health Organization that's causing for an end to coercive practices and radical changes within the mental health system. I mean, I've been coming here a long time, and this isn't my only friend that I've been visiting in hospital who's died at a young age, who's been in the system all their adult life.
Wendy, thank you for that, and please accept our condolences for the loss of your friend. On the housing issue, the South West London is working in partnership with South East London through South London Listens. It will be reported through the Integrated Care Partnership Board rather than through this board, but we are establishing a special housing project looking at housing first as you suggested. So please feel reassured, we are working in that area, but it's more likely to be presented through the Integrated Care Partnership Board than through this board, which is much more focused upon NHS services directly. Vanessa, I don't know whether, I know you have conversations with Wendy quite frequently, but if there's anything you wanted to add from the board's point of view.
So again, I reiterate condolences, Wendy, and I also thank you for reminding us of the significant health inequalities for mental health itself and the mortality gap between mental health and the people with mental health conditions and the rest of the population. We're doing a lot of work, as you know, around reducing restrictive practices, and that work does get reported through the quality arm, and maybe we could again share some of that work with you and the people so that you can see the work that we're doing in those areas.
People can see it on the website, the data's there and from the Freedom of Information Act, but I mean, forced medication, just depots. I mean, what my friends tell me, I mean, you go in and you have to take down your trousers and be injected, and it's a humiliating experience. Every aspect of it. It's acknowledged by the UN and World Health Organization. And you know that in Italy they don't have mental health hospitals as such. I mean, it has to change. It just can't keep going on like this.
Thank you. Are there any other questions from members of the public? In which case I will formally close the meeting. Reminder that the next meeting is on the 18th of September here. But before we go, please could we give a round of applause as this is the last meeting for Ruth Bailey, and thank her for her work on this board.
Thank you.
Thank you. Look forward to seeing you. Enjoy the rest of the summer. Look forward to seeing you again soon.